Welcome to the Deep Dive. We take your sources, unpack the complexity, and distill the knowledge. Today, we're diving into something that touches, well, pretty much all our lives, directly or indirectly. Cancer. Our source is a foundational text, a chapter on the principles of oncology, from Bailey and Love's Short Practice of Surgery.
A classic.
Absolutely. And our mission in this deep dive, to really get under the hood of cancer, guided by this respected source. We want to understand its fundamental nature, where it comes from, how it behaves in ways that just seem to break all the rules, and the broad principles that guide how we diagnose, stage, and manage it. We're really going for a detailed exploration here, aiming to grasp this topic with the kind of depth professionals in the field strive for.
And it's fascinating, isn't it? It's a journey built on centuries of observation and discovery. I mean, think about the word itself, cancer.
Right.
It's said to go back to Hippocrates, the ancient Greek physician. He apparently used the word karkinos, which means crab.
Because of the way it looked.
Seemingly, yeah. The finger-like projections of a tumor mass apparently reminded him of a crab's claws. So from those, ancient visual descriptions to today's molecular maps, it's been quite an evolution in understanding.
Okay, let's unpack this then. At the most fundamental level, what is cancer, according to our source?
Well, it's described as a disease of cells. And this idea, it really goes back to pioneers like Rudolf Virchow, his famous dictum, omnis cellula e cellula, every cell from a cell.
Right, cells come from other cells.
Exactly. It established that cells arise from pre-existing cells, so cancer is characterized by this abnormal proliferation, just uncontrolled growth of these cells. But the real leap in understanding why this happens, that came with molecular biology.
The DNA connection.
Precisely. Identifying DNA as the genetic material, Watson and Crick describing its structure, that's when we started to grasp cancer as a disease rooted in changes right down at the genetic and molecular level within our cells.
So it's a fundamental breakdown at the cellular blueprint level.
Yeah.
What does that mean for how these cancer cells actually act? What makes them so dangerous compared to a normal cell?
They essentially, they break the rules of multicellular life. Normal cells are, tightly controlled. They divide when needed, stop when told, stay put in their tissue.
Right, they cooperate.
They cooperate. Cancer cells, they just proliferate uncontrollably. Their ability to divide and spread becomes, unbounded. And this unchecked behavior, ultimately, it destroys the tissue they came from.
And the person.
And the organism they inhabit, yeah.
The source talks about the hallmarks of cancer, based on Hanahan and Weinberg's work. This sounds like the core playbook, the strategy guide for a cancer cell. What are these key characteristics they need to acquire?
That's a great way to think about it. It's like a set of capabilities malignant cells need to survive, divide endlessly, invade, and spread. It's not usually just one thing, but a combination.
A toolkit.
A toolkit, exactly. And what's fascinating is that not every single hallmark is strictly necessary for every single cancer. But these are the big ones, the common strategies. So first, they figure out how to establish an autonomous lineage. Normal cells need signals, right? External cues to grow and divide. Cancer cells, they become independent.
They don't wait for permission.
Nope. They escape the normal checks and balances, like the signals that coordinate cell growth during, say, wound healing.
Like just ignoring a stop sign.
Pretty much. Which ties right into the next one. They resist signals that inhibit growth. They just, blow right past the messages telling them, okay, that's enough, stop dividing now.
So they ignore the stop signs and the brake pedal signals.
And they actively work to sustain proliferative signaling. They can start generating their own internal ghost signals, or they become hyper-responsive to external signals, constantly pushing the gas pedal on growth when they shouldn't be.
Okay, constant go.
Yeah.
What else?
This next one is really crucial. Replicative immortality. Normal cells, they have a limited lifespan in terms of divisions, maybe 40 to 60 times. It's the Hayflick limit.
Linked to telomeres, right, the chromosome cap.
Exactly. Those telomeres shorten a bit with each division. When they get too short, the cell usually stops dividing or undergoes programmed cell death. Cancer cells find a way around this. Very often, they reactivate an enzyme called telomerase.
And that rebuilds the telomeres.
It rebuilds the telomeres after each division, so it grants them this sort of biological immortality. The cell lineage can just keep dividing, potentially forever.
So they don't just grow uncontrollably, they can essentially live forever, too, in terms of dividing.
In that sense, yes, their lineage does. They also need to evade apoptosis. Apoptosis is programmed cell death. It's a neat, orderly self-destruct process for old, damaged, or unneeded cells, vital for development, tissue balance.
Like leaves falling in autumn, the source says. Controlled.
Exactly, it's programmed. Cancer cells avoid this. Often, it's because critical suicide switch genes, like the famous tumor suppressor gene P53, get mutated. If P53 is broken, the cell loses that vital safety mechanism for eliminating damaged or abnormal cells.
So immortal, and they refuse to die when they should. What about getting bigger?
Right. To grow into a significant mass, they must acquire angiogenic competence. A tumor just can't get bigger than about 1 millimeter across without its own blood supply. It needs oxygen, nutrients.
So these plumbing.
It needs plumbing. Cancer cells gain the ability to attract or actually build new blood vessels. That's angiogenesis. This is absolutely essential for a tumor to grow large and also gives it a route to potentially spread elsewhere.
They basically build their own supply lines.
Precisely. And then they need to acquire the ability to invade, disseminate, and implant. They stop respecting the normal tissue boundaries, like the basement membrane that usually keeps cell layers contained.
How do they breach those walls?
A few ways. They can increase pressure just from their own growth. They secrete enzymes. Think of them as molecular scissors that dissolve the surrounding tissue matrix, the glue holding things together. And they change their cell surface molecules, making them more mobile, letting them detach from their neighbors. There's this process called epithelial mesenchymal transition, or EMT.
Which happens normally sometimes.
Yes, in development. But cancer cells hijack it for their own purposes, becoming more migratory. But just getting into a blood vessel or a lymph vessel, that isn't enough. They have to successfully disseminate an implant at a distant site to form a metastasis. That's the really dangerous part for many cancers.
Seed and soil idea.
Exactly. The source references Paget's hypothesis from way back. The cancer cell is the seed, the distant organ is the soil. Both need to be compatible. Most cancer cells that get into the bloodstream probably just die.
Really? Most of them?
Probably, yeah. Successful implantation might involve the cancer cells manipulating the local environment in that distant organ, maybe even co-opting the body's normal inflammatory responses to help them settle in.
You mentioned inflammation. The source also lists evocation of inflammation as a hallmark. That seems counterintuitive. Isn't inflammation supposed to fight problems?
It normally is, yes, part of the body's defense. But in the context of malignancy, the inflammation caused by or around a tumor can paradoxically help the cancer thrive.
How so?
Well, the factors released during inflammation, things like growth factors, molecules that stimulate blood vessel growth, those angiogenic factors again, even reactive oxygen species, or ROS, can actually promote tumor growth, help it progress, and even protect cancer cells from death signals. It becomes this complex, often self-reinforcing cycle that benefits the tumor.
Okay, so inflammation can be co-opted. What else is in their toolkit?
Another key survival trick is to evade detection elimination by the immune system. Our immune system is constantly patrolling, and it should recognize cancer cells as abnormal, as not quite self.
Immune surveillance.
Exactly. That concept suggests the immune system probably eliminates nascent cancers all the time without us ever knowing. But the ones that become clinically apparent, the ones that cause disease, they've figured out how to hide or fight back.
How do they hide?
They might stop displaying the abnormal proteins, the antigens, that would flag them to immune cells, or they might actively suppress the immune cells that arrive. This is precisely where a major area of modern therapy comes in T-cell checkpoint inhibitors.
Right, taking the brakes off the immune system.
Exactly. Blocking the signals cancer cells use to shut down T-cells.
And they often undergo a loss of specialist cell function, don't they?
They do. Their main priority becomes dividing and surviving. So they often downregulate or lose the genes that define their original job, whether they were supposed to be liver cells or lung cells or whatever. They become less differentiated.
Does that have implications for treatment?
It can. It might affect how aggressive they are, and sometimes this loss of specialized function might create vulnerabilities that can be exploited by certain treatments. And finally, they develop the ability to change energy metabolism. Tumors often have really poor, disorganized blood flow, which leads to low oxygen conditions, hypoxia, especially in the center.
So they have to adapt.
They have to adapt to survive in those hypoxic states. And interestingly, even when oxygen is available, many cancer cells shift their metabolism. They prefer something called aerobic glycolysis, also known as the Warburg effect.
They don't use oxygen efficiently.
Right. Instead of efficiently generating energy in the mitochondria using oxygen, they rely more on this less efficient process that produces lactate as a byproduct. And the source notes something fascinating. Adjacent normal cells, or even other cancer cells, can sometimes use this lactate produced by the Warburg effect cells as fuel, a kind of metabolic cooperation or symbiosis within the tumor microenvironment.
That list, it really paints a picture of a cell that's just gone completely rogue, acquired this whole suite of abilities just to survive and multiply, breaking every rule.
It's a profound biological reprogramming.
The source also talks about the growth of a cancer mass, starting, in theory, from that single transformed cell.
That's the theoretical origin, yes. A single cell that accumulates enough critical genetic changes to become cancerous. And if you just do the simple math, cell division is exponential, 2 to the power of n.
It seems incredibly fast.
It does. To reach a tumor that's clinically detectable, maybe about a centimeter across, which is roughly 109 cells, that theoretically only takes around 30 cell divisions.
Only 30.
From that one starting cell, yeah. And then to reach a potentially fatal burden, say 10, 13, or 10, 14 cells, takes surprisingly few more divisions. Fewer than 15 additional doublings, getting you to around 45 total divisions from that single cell.
Wow. That sounds terrifyingly fast, going from detectable to potentially lethal.
It really does when you look at that simple exponential model. But, as the source rightly highlights, it's a significant oversimplification.
Okay, why?
Well, in reality, many cancers have substantial cell loss throughout their growth. It's not just constant accumulation. For some cancers, like squamous cell carcinomas, maybe 99% of the cells produced are actually lost due to processes like shedding or dying off.
99%. So it takes way more divisions then.
Exactly. It means it actually takes many, many more divisions than that theoretical 45 total to reach a detectable or lethal stage. Tumor growth also often isn't purely exponential. It often follows what's called a Gompertzian curve.
Gompertzian?
Yeah, it starts off relatively exponential, but then the growth rate, the doubling time, actually slows down as the tumor gets larger.
Why does it slow down?
Likely due to increasing competition for resources. As the mass gets bigger, cells, especially in the center, struggle to get enough nutrients and oxygen because the tumor's blood supply often can't keep up or is poorly organized, so growth slows.
Okay, that makes sense. So this complex process, a cell going rogue, acquiring these hallmarks, where does it all start? The source emphasizes this interplay between nature and nurture.
Absolutely. That's a fundamental concept in oncology. Both our inherited genetics, our nature, and our environmental exposures, our lifestyle, our nurture, play crucial roles.
And the balance is different for different cancers.
Exactly. The balance really shifts depending on the specific cancer type. Think about lung cancer. Smoking is such a powerful environmental factor linked to maybe 80% of cases, though importantly, not all smokers get lung cancer, so there's still an interplay.
Right.
Contrast that with certain rare inherited cancer syndromes, like those caused by mutations in the BRCA1 or BRCA2 genes. If you inherit one of those mutations, your lifetime risk of breast and ovarian cancer is dramatically increased, maybe 60, 90%. In that case, the genetic predisposition, the nature part, is much more dominant.
And understanding these causes, both nature and nurture, is key for prevention and for early detection strategies, isn't it?
Absolutely crucial. The source provides tables with examples, which we obviously can't list exhaustively.
No, but let's pick out some important categories from those tables that professionals dealing with cancer encounter. What about the inherited side?
Sure. Looking at Table 12.1 in the source, these inherited syndromes often involve mutations in really critical genes that normally control cell growth, repair DNA damage, or trigger apoptosis. We mentioned BRCA1, BRCA2 for breast and ovarian cancer.
Right.
Others include mutations in the APC gene, which causes familial adenomatous polyposis, or FAP. People with FAP develop hundreds, even thousands, of polyps in their colon, and without intervention, colorectal cancer is almost inevitable.
Wow.
Then there's Lynch syndrome, linked to mutations in genes like MLH1 or MSH2, which are involved in DNA mismatch repair. That increases the risk for several cancers, particularly colorectal, uterine, and ovarian.
So how are these managed?
Management for individuals and families with these syndromes often involves genetic testing to identify who's at high risk. Then, really intense surveillance, like for FAP, very frequent colonoscopy starting young, and sometimes preventative surgeries, like removing the colon or ovaries, are considered to drastically reduce the risk. Genetic counseling is a huge part of this.
Okay, that's the nature side. What about the nurture side, the environmental and lifestyle factors? Table 12.2.
That list is extensive and probably accounts for the majority of cancers overall. We know tobacco is a massive one. Alcohol is a clear risk factor. UV radiation from some exposure linked to skin cancers. ionizing radiation.
And infections.
Yes, a significant group are caused by infectious agents. Human papillomavirus, HPV, is a major cause of cervical cancer and increasingly head and neck cancers. Hepatitis B and C viruses are strongly linked to liver cancer. The bacterium Helicobacter pylori can cause stomach cancer.
That's surprising, a bacterium.
It is. And even parasites schistosomiasis, common in some parts of the world, is linked to bladder cancer. HIV infection increases the risk of certain lymphomas and Kaposi sarcoma.
What else is on that list?
Occupational exposures are important. Asbestos-causing mesothelioma is a well-known example, but there are various industrial chemicals, too. Even some medical treatments, like certain chemotherapy drugs or long-term immunosuppression after transplants, can slightly increase the risk of secondary cancers later on. Lifestyle factors are huge. Obesity is now recognized as a contributor to multiple cancer types, as is lack of physical activity. Diet plays a role too, though the specifics can be complex. Even things like aflatoxins, which are fungal toxins found in contaminated food, are mentioned.
So the prevention strategies must be incredibly diverse too.
They are. Everything from public health measures like smoking bans and taxes, to vaccinations like the HPV vaccine, occupational safety regulations, public awareness campaigns about sun protection, and then all the individual choices about diet, exercise, alcohol consumption, and so on.
It really drives home that managing cancer is so much broader than just treating the tumor once it's there. It's this whole continuum.
Absolutely. That full spectrum view is vital. It spans primary prevention, stopping cancer before it starts, secondary prevention through screening, then accurate diagnosis and staging, choosing and delivering effective treatment, managing the side effects of that treatment, follow-up care to monitor for recurrence, rehabilitation to help people recover function, symptom control, palliative care, all the way through to end-of-life care when needed.
Let's focus on screening for a bit. Why is it important, and what are some of maybe the nuances or even pitfalls we need to understand when we talk about screening?
Okay, screening. The fundamental goal is to detect disease in people who don't have any symptoms. The hope is to catch the cancer at an earlier stage when treatment is more likely to be curative, leading to better outcomes.
Makes sense.
But for a screening program to be worthwhile, several conditions need to be met. The cancer needs to have a recognizable early stage where treatment is genuinely more effective than treating it later, and it needs to be common enough in the population you're screening to justify the cost and effort.
And the test itself has to be good, right?
Absolutely. The screening test needs certain qualities. It needs to be sensitive, meaning it's good at finding the disease if it's actually there, so you have few false negatives.
Okay.
And it needs to be specific, meaning it's good at correctly identifying people who don't have the disease, so you have few false positive, which can cause anxiety and lead to unnecessary further tests. Plus, the test needs to be acceptable to the population. People have to be willing to undergo it. It has to be safe. And ideally, reasonably inexpensive if you're doing it on a large scale.
So intuitively, if you find a cancer earlier through screening, the person should live longer because of that screening, shouldn't they?
Yeah. Ugh. This is where it gets really interesting and where understanding the potential biases in interpreting screening results is absolutely critical. Just looking at survival time from diagnosis and comparing people whose cancer was found by screening versus those whose cancer was found because they developed symptoms, that comparison can be very, very misleading.
Misleading, how?
There are three main biases you have to be aware of. The source explains them well. First, there's lead time bias. Imagine, as shown in figure 12.4, screening finds the cancer at point A. Symptoms wouldn't have appeared until much later at point B if the person unfortunately still dies at the same time, point C.
Okay.
The survival time measured from the screening diagnosis, A to C, looks much longer than the survival time measured from when symptoms would have appeared, B to C. But the screening itself didn't actually make the person live any longer in this scenario. It just started the clock earlier. That extra time is the lead time.
Okay, so it artificially inflates the survival time just because you found it sooner. What's the second bias?
Second is selection bias. Think about who volunteers for screening programs. Often it's people who are generally more health conscious, maybe have healthier lifestyles, maybe better access to healthcare overall.
Right, they might do better anyway.
Exactly. This healthy volunteer effect means the group getting screened might have better outcomes regardless of the screening itself, just because they're a healthier group to begin with compared to those who don't participate.
Okay, lead time selection bias. Well, what's the third one?
The third is length bias. Screening tests, especially if done at regular intervals, are statistically more likely to detect slow-growing, less aggressive tumors. Why? Because those tumors exist in a detectable pre-symptomatic state for a longer period, giving the screening test more opportunity to find them.
Whereas the fast-growing ones.
Fast-growing, really aggressive tumors might develop and cause symptoms quite quickly, perhaps between screening rounds, so they're more likely to be diagnosed symptomatically. This means the group of tumors detected by screening tends to be enriched for the slower-growing, inherently less aggressive types compared to the group found because of symptoms.
So if you just compare survival, the screen-detected group looks much better, partly because they found it earlier, lead time, and partly because they disproportionately found the less aggressive cancers, length bias, and maybe the people getting screened were healthier anyway, selection bias.
You've got it. That's why just comparing survival from diagnosis between screened and unscreened symptomatic groups is fundamentally flawed. To truly know if a screening program saves lives from that specific cancer, you need large, well-conducted, randomized controlled trials.
The gold standard.
The gold standard. These trials randomize whole populations to either be offered screening or not, and then they compare the death rate from that specific cancer in the two groups over many years. This kind of rigorous evidence has shown that screening can reduce mortality for breast cancer and colorectal cancer.
But it's difficult to prove it reduces overall mortality.
Very difficult because you need enormous numbers of people followed for a very long time to see a statistically significant difference in death from all causes, not just the cancer being screened for. Screening remains a complex area, sometimes controversial, but newer approaches like risk-based screening, targeting screening to those at highest risk, like lung cancer screening for heavy smokers, are being actively evaluated.
All right, so navigating screening requires understanding those biases. Let's move on. Once cancer is suspected, perhaps from screening or symptoms, the next crucial step is diagnosis. And the source is emphatic. You need tissue.
Fundamentally, yes. It's extremely rare to diagnose cancer with certainty without getting a tissue sample, a biopsy, and having a pathologist examine the cells under a microscope. That pathological or cytological examination is the cornerstone.
And that's where classification comes in, like grading.
Exactly. Classification systems vary by tumor type, but often involve grading, like G1 to G3, based on how much the cancer cells resemble normal cells, how differentiated they are. Some cancers have specific systems, like the Gleason score for prostate cancer, which is based more on the architectural pattern of the glands.
And increasingly, it's not just how the cells look, but there are molecular details that are driving diagnosis and especially treatment, right?
Absolutely. This is one of the biggest shifts in oncology. Analyzing the tumor's molecular profile, looking for specific genetic mutations, protein expression levels, other features, is profoundly changing how we approach treatment for many, many cancers.
Personalized medicine.
It's the foundation of personalized or precision medicine. If you can identify a specific vulnerability in that patient's tumor, like a BRAF mutation in melanoma or HER2 amplification in breast cancer or EGFR mutations in lung cancer, we now have targeted therapies designed specifically to attack that vulnerability. Finding these druggable targets through molecular testing is becoming standard of care.
Okay, so we know what the cancer is down to the molecular level, but we also need to know where it is and how far it's spread. That's staging.
Staging, exactly. It's about mapping the geographical extent of the disease within the patient's body. This is absolutely critical because it determines the treatment strategy. Is the cancer localized enough that surgery or radiotherapy might be curated on their own? Or has it spread widely, meaning systemic treatment drugs that travel throughout the body is necessary?
And staging has become much more sophisticated.
Immensely so. We've moved from relying on just physical exams and basic x-rays to incredibly detailed imaging like CT scans, MRI, and PT scans. This means that a patient staged as having localized disease today might actually have a truly smaller burden of disease than someone given the same stage years ago, simply because our tools for detecting small amounts of spread are so much better now.
The standard system for staging is the TNM system, mentioned in the source.
Yes, the TNM system, developed by the UICC and AJCC, is the global standard for most solid tumors. Table 12.3 gives the example for colorectal cancer. N stands for the involvement of regional lymph nodes, and M stands for the presence or absence of distant metastases.
And its purpose is twofold.
Exactly. It serves two main purposes. First, to help estimate the patient's prognosis generally. Higher stage means a worse prognosis. And second, perhaps more importantly, to select the appropriate treatment. Anatomical staging tells you about surgical resectability and the risk of the cancer coming back locally.
But even staging is evolving, becoming more refined with technologies like circulating tumor DNA, ctDNA.
This is a really fascinating and potentially game-changing advancement that the source highlights. The idea is to detect tiny amounts of DNA shed from the tumor into the bloodstream. Early studies are showing that detecting ctDNA in a patient's blood after potentially curative surgery is a powerful predictor of relapse.
So it indicates residual disease.
It strongly suggests the presence of microscopic residual disease that the surgery didn't remove. This information could be incredibly valuable. It could help us select which patients really need additional treatment after surgery, adjuvant therapy, to target that residual disease. And, just as importantly, it could help identify patients who are likely cured by surgery alone and can safely avoid the toxicity of further treatment.
That would be huge.
It really could personalize post-surgical treatment decisions much better.
Okay, so you've got all of this incredibly complex information. The pathology report, the molecular analysis, the sophisticated staging data. It sounds like making the right treatment decision requires input from many different specialists. The source really emphasizes the multidisciplinary team, the MDT.
Absolutely. Modern cancer management is just too complex for any single clinician to master all aspects. Multidisciplinary teams, MDTs, sometimes called tumor boards, are essential. They bring together specialists from all the relevant fields.
Like who?
Asians, medical oncologists who manage drug therapies, radiation oncologists who manage radiotherapy, radiologists who interpret the scans, pathologists who analyze the tissue, palliative care specialists, specialist nurses, often social workers, dietitians. The list is in summary box 12.3. The idea is that by discussing each patient's case together, considering all the evidence and different perspectives, they can arrive at the most appropriate evidence-based management recommendation.
What are the main benefits of this team approach? And are there any drawbacks?
The benefits, listed in Table 12.4, are pretty clear. You get open debate among experts, which should lead to better decisions. The process is more transparent. It's a great educational environment for everyone involved, including trainees. And it allows for monitoring of treatment outcomes for the whole team.
But the downsides?
There can be downsides. MDTs can sometimes become a bit of a rubber stamping exercise if not run well. A key criticism is that decisions are often made without the patient being present in the room. There's a potential for diffusion of individual responsibility. It's a team decision. And practically, they are very resource-intensive and time-consuming, requiring many busy specialists to coordinate schedules.
What are the core questions the MDT is trying to answer when they discuss a patient?
They're trying to synthesize all the information to answer. What is the precise diagnosis, including the molecular subtype? What is the exact stage? Based on that, what is the goal of treatment for this specific patient? Is cure realistic? Is the aim to prolong life? Or is the focus primarily on palliation, controlling symptoms? And then what are the available treatment options? Surgery, radiotherapy, systemic therapy, symptom management, maybe a combination, maybe even active observation that offer the best chance of achieving that goal with the most acceptable side effects.
But the MDT makes a recommendation. The final decision isn't made in the MDT meeting, right?
Crucially, no. The MDT provides an expert recommendation based on the objective medical data. But the final treatment decision has to be made in consultation between the treating clinician and the patient. Several vital factors require that direct clinician-patient assessment, such as the patient's overall physical fitness and their ability to actually tolerate the proposed treatment. This is influenced by their age, yes, but more importantly by their other medical conditions, comorbidities, and their overall level of frailty. The source rightly reminds us that chronological age alone isn't a good measure of fitness. An older person can be very fit, and a younger person can be frail.
And the patient's own preferences.
Absolutely paramount. Understanding the patient's own wishes, their values, how they weigh the potential benefits of treatment against the potential burdens and side effects. How do they balance the chance of cure or extending life against maintaining quality of life? Explaining these complex trade-offs, the probabilities, the uncertainties, it takes time, skill, and often repetition, especially considering how vulnerable patients are when facing these decisions.
Okay, let's delve into the treatments themselves. For many solid tumors, surgery is often the first major intervention.
For the majority of solid cancers, yes, surgery offers the only realistic prospect of cure by physically removing the primary disease.
But it has other roles too, besides just aiming for cure by removing the main tumor.
Definitely. Surgery plays multiple roles in cancer management. It's often essential for diagnosis and staging. While we usually try to get a biopsy before major surgery, sometimes the surgery itself is needed to get the diagnosis. Think of removing a suspicious kidney mass or a testicular tumor or an enlarged lymph node. Laparoscopic surgery, keyhole surgery, is also frequently used for staging abdominal cancers, as it can detect small metastases on surfaces like the peritoneum that might be missed by scans.
And sentinel node biopsy.
Sentinel node biopsy is another key surgical staging technique, particularly in melanoma and breast cancer. It involves identifying and removing just the first lymph node that drained the tumor site to see if cancer cells have spread there. That avoids removing many more nodes unnecessarily if the sentinel node is clear. But the primary role, of course, is removal of the primary disease. Radical surgery aims to remove the tumor completely, along with a margin of surrounding healthy tissue and often the regional lymph nodes, to achieve local control. The source emphasizes that meticulous surgical technique here is absolutely vital for maximizing the chance of cure and preventing the cancer from recurring locally, though it also notes that going for ultra-radical surgery doesn't necessarily improve survival if the disease has already spread distantly. Interestingly, surgery can sometimes be used for removal of metastatic disease. While widespread metastases usually mean the cancer isn't curable by local means, there are important exceptions. Surgery to remove liver metastases from colorectal cancer, for example, can be curative in selected patients. Same for removing isolated lung metastases, particularly from kidney cancer or sarcomas. Sometimes ablation techniques using heat or cold are used instead of cutting them out.
So even with spread, surgery can sometimes still aim for cure.
In specific circumstances, yes. And finally, surgery has a very important palliative role. Even when cure is completely off the table because the cancer is too widespread, surgery can still significantly improve a patient's quality of life by removing a primary tumor that's causing major symptoms like bleeding, obstruction, or severe pain.
Okay, that covers surgery. Beyond that, we have the vast and rapidly evolving fields of medical oncology and radiation oncology, the non-surgical treatments.
Yes, a huge area. And again, the principles of decision-making start with the MDT, understanding the diagnosis, stage, molecular features, and the patient's fitness and goals. A general principle mentioned is that if a local treatment, like surgery, or perhaps highly focused radiation, ablation, is likely to be just as effective as a systemic treatment for localized disease, the local option is usually preferred to avoid systemic side effects. But the specific choices of non-surgical therapy are highly dependent on the tumor type and are constantly being updated by clinical trials.
What are the main purposes or settings in which these non-surgical treatments are used?
The source outlines several key contexts. First, as curative primary treatment. In some cancers, non-surgical treatment alone offers a high chance of cure. Examples include radiotherapy for some early-stage head and neck cancers or prostate cancer, and chemotherapy for certain leukemias and lymphomas. Table 12.5 lists more examples. Second, neoadjuvant treatment. This means giving treatment before the main local therapy, which is usually surgery. The goal might be to shrink the tumor to make surgery easier or less extensive, like breast-conserving surgery instead of mastectomy, or sometimes to make an initially inoperable tumor operable. A classic example is giving radiotherapy, often with chemotherapy, before surgery for rectal cancer. Third, adjuvant treatment. This is treatment given after potentially curative surgery. The aim here is to eradicate any tiny invisible cancer cells, micrometastases, that might have been left behind or already spread, thereby increasing the overall chance of cure. Giving chemotherapy or hormone therapy after breast cancer surgery is a very common example. And fourth, life-prolonging or palliative treatment. The source makes an important distinction here. Life-prolonging systemic therapy aims to extend survival in the setting where cure isn't possible, maybe by months or even years, while ideally maintaining good quality of life. Think of drugs like olaparib for certain types of ovarian cancer. Palliative treatment, on the other hand, has the primary goal of relieving symptoms and improving comfort, although it might sometimes incidentally prolong life as well.
Systemic therapies, the drug treatments, seem to be where a lot of the most dramatic recent advances have occurred.
They certainly have. The whole approach has shifted significantly. We used to rely more heavily on cytotoxic chemotherapy drugs, which were often discovered through broad screening and tend to kill any rapidly dividing cell, cancer, or normal. Now, with our much deeper molecular understanding of what drives specific cancers,
We can be more targeted.
exactly, we can identify specific druggable targets, key molecules, or pathways that a particular patient's cancer relies on and design drugs specifically to inhibit them. This has led to some incredibly effective targeted therapies. But the field is moving so fast, Keeping up with all the new agents and combinations is a major challenge, even for specialists.
What are the core principles that guide clinicians when selecting and using these systemic therapies for an individual patient?
Several crucial principles are outlined in the source. First, and always, it comes back to assessing the patient's fitness and their ability and willingness to tolerate the proposed treatment. Considering their age, yes, but more importantly, their comorbidities, their functional status, their overall frailty. Second, the importance of supporting the patient to understand the complex options and participate in the decision-making based on their own values. This involves clear, honest communication about the prognosis, what the treatment actually involves, frequency, side effects, the potential benefits, how likely, how much, and the potential downsides, helping them weigh quality versus quantity of life. This takes time, empathy, and real skill.
Communication is key.
Absolutely vital. And third, there's the constant need to reassess the risk-benefit balance during the course of treatment. Before every cycle of therapy, the clinical team needs to ask, is the treatment actually working? Often assessed with scans to see if the tumor is shrinking or stable. Is the patient tolerating the side effects? How is it impacting their quality of life? And is it safe to give the next dose? This involves monitoring for side effects and checking lab tests, blood counts, kidney function, liver function, etc. Treatment needs to be adjusted or stopped if the harms start to outweigh the benefits.
The source uses adjuvant therapy as a really good example of this challenge of balancing risk and benefit, especially when you're treating microscopic disease you can't even see.
It's a perfect illustration, shown well in figures 12.5 and 12.6. When you give adjuvant therapy after surgery, you traditionally haven't had a perfect test to know for sure who actually has remaining microscopic disease. So, as figure 12.5 shows, you might treat, say, 100 patients who've had surgery. Maybe 70 of them were already cured by the surgery alone. Maybe another 15 have residual disease, but it's resistant to the adjuvant therapy you're giving. So you're treating all 100 patients, exposing them all to potential side effects.
To benefit only a small proportion.
To potentially benefit only the maybe 10–15% who do have residual disease and whose disease is sensitive to that therapy. For that small group, the benefit is huge. It's the difference between cure and recurrence. But for the vast majority, the treatment was either unnecessary or ineffective.
That's a tough calculation.
It is. And that's where the hope for technologies like ctDNA comes in, as shown in figure 12.6. If ctDNA testing after surgery can accurately identify that high-risk group who truly have residual disease, you could potentially target adjuvant therapy much more effectively, treating only those likely to benefit and sparing the rest from unnecessary toxicity.
Much more personalized.
Exactly, reducing overtreatment.
Let's briefly touch on the main types of systemic drugs listed in Table 12.6, just the broad categories and how they work.
Sure. Broadly speaking, you have the traditional cytotoxic chemotherapy drugs. These work in various ways, interfering with DNA synthesis, directly damaging DNA, disrupting the mitotic spindle needed for cell division. They tend to hit rapidly dividing cells the hardest, which includes many cancer cells, but also normal cells in places like the bone marrow, hair follicles, and gut lining, hence the common side effects. Then there are hormonal treatments or endocrine therapies. These are used for cancers that are sensitive to hormones, like many breast cancers, estrogen receptor positive, and prostate cancers, androgen sensitive. They work by blocking the production or action of those hormones. Then the more modern classes. Targeted treatments, which we've discussed these, are designed to inhibit specific molecular targets known to be driving the cancer's growth or survival, often identified through molecular testing of the tumor. And finally, immunological mediators or immunotherapies. These don't target the cancer cell directly, but instead aim to activate or enhance the patient's own immune system to recognize and attack the cancer.
Can you elaborate a bit more on those targeted therapies and immunotherapies? They represent such significant progress based on that deeper biological understanding.
Definitely. Targeted therapies really are the embodiment of personalized medicine. Their use depends on finding that specific druggable target in the patient's tumor. Examples mentioned in the source include vemurafenib for melanomas with a specific BRAF gene mutation, or imatinib for gastrointestinal stromal tumors, GSS, driven by KIT mutations, or trastuzumab for HR-positive breast cancer. The prerequisite is molecular analysis of the tumor tissue. They aim for specificity, hitting the cancer's Achilles heel, but they aren't without side effects, sometimes off-target effects on other molecules, or on-target effects if the target molecule is also important in some normal tissues. Immunotherapy, particularly the checkpoint inhibitors, has been revolutionary for some cancers. Building on that idea of immune surveillance, we now know cancer cells can actively evade the immune system by expressing proteins on their surface that engage with checkpoints on immune cells, basically telling the immune cells, don't attack me.
Putting the brace on.
Putting the brakes on the immune response. Drugs like ipilimumab, which targets CTLA-4, or pembrolizumab and nivolumab, which target PD-1 or its ligand PD-L1, block these interactions. They release the brakes, allowing the patient's T cells to recognize and kill the cancer cells. This has led to dramatic and durable responses in some patients with previously very difficult to treat cancers like metastatic melanoma, lung cancer, and others.
Are they better tolerated than chemo?
Often, yes, in terms of the typical chemo side effects like nausea and hair loss. However, because they work by unleashing the immune system, they can cause a unique set of side effects called immune-related adverse events, where the activated immune system mistakenly attacks normal tissues, causing things like colitis, hepatitis, pneumonitis, or endocrine problems. Managing these requires vigilance. It's a very active area of research, looking at combinations, vaccines, engineered immune cells like CRNT cells, and more.
Okay, the other major non-surgical treatment pillar is radiotherapy. How does that work at a fundamental level?
Radiotherapy, or radiation therapy, is used in about half of all cancer patients at some point. It uses high-energy ionizing radiation like X-rays or gamma rays to kill cancer cells, primarily by damaging their DNA.
Directly hitting the DNA.
Some damage is direct, yes, but the major mechanism, as the source explains, is actually indirect. The radiation interacts with water molecules within the cell, creating highly reactive molecules called oxygen-free radicals. And it's these free radicals that then cause most of the DNA damage, leading to breaks in the DNA strands.
So oxygen is important.
Very important. This reliance on oxygen-free radicals helps explain why cells in low oxygen or hypoxic areas of a tumor are often less sensitive to radiation. They're radioresistant. Ensuring adequate oxygenation, for example, by correcting anemia so the blood can carry more oxygen, can actually help make radiotherapy more effective. Sensitivity also varies quite a bit between different cancer types, and the dose used depends on whether the goal is cure or palliation.
It's described as a localized treatment, unlike systemic therapy. How is that precision targeting achieved?
Precision is absolutely key. The process of planning and delivering radiotherapy is highly technical, as shown in Figure 12.7. First, you need to define the target volume very accurately. This relies heavily on high-quality imaging. CT scans are the backbone, often fused with MRI or PET scans, to get the best possible picture of the tumor and its relationship to nearby healthy organs that need to be avoided.
So you map it out in 3D.
Exactly. Then, sophisticated computer planning systems are used to design the treatment. Techniques like 3D conformal therapy or more advanced intensity-modulated radiation therapy, IMRT, allow the radiation beams to be shaped very precisely to conform to the tumor shape while minimizing the dose hitting surrounding normal tissues. The goal is always to optimize the therapeutic ratio, maximize the dose to the tumor, minimize the dose to healthy tissues.
How do you make sure the patient is in the right position each day?
That's where image-guided radiation therapy, or IGRT, comes in. This involves taking images, like CT scans or X-rays, of the patient on the treatment machine just before or even during the treatment delivery each day. This allows the team to verify the setup is accurate and make tiny adjustments to account for patient movement or internal organ motion, ensuring the radiation goes exactly where it's planned.
Are there other ways to deliver radiation?
Yes. Techniques like stereotactic ablative radiotherapy, SABR, also called stereotactic body radiation therapy, SBRT, use highly focused beams to deliver very high doses of radiation in just a few treatment sessions to small, well-defined tumors. Brachytherapy involves placing radioactive sources directly inside or very close to the tumor, and radionuclide therapy uses radioactive drugs that are injected or swallowed and are specifically taken up by cancer cells delivering radiation from within. A significant challenge with radiotherapy, though, is the time lag for late side effects. While acute side effects occur during or shortly after treatment, late effects on normal tissues like fibrosis, nerve damage, or organ dysfunction can sometimes take years or even decades to fully manifest. This makes it difficult to quickly assess the long-term safety of new techniques or fractionation schedules.
Given the different ways these treatments work, surgery, removing bulk, radiation hitting locally, drugs acting systemically, it makes sense that they're often combined. What's the main rationale behind using multiple treatments together?
The primary reason, fundamentally, is to overcome or prevent treatment resistance. By the time a cancer is diagnosed, it's usually not just one type of cell. Due to genetic instability, it's often a heterogeneous mix of different cell populations, or clones. Some of these clones might, just by chance, already have mutations that make them resistant to a particular type of treatment, even if they've never been exposed to it.
So using just one treatment might kill off the sensitive cells.
but leave the resistant ones behind to regrow.
Exactly. By using multiple treatments with different mechanisms of action, ideally simultaneously or in close succession, you significantly reduce the probability that any single cancer cell will be resistant to all the treatments being used. It makes it much harder for resistant clones to survive and expand. It's the same principle behind using combination antibiotics for serious infections.
What principles guide which treatments are combined and how? The source lays out 4 key principles for combining treatments, particularly systemic therapies, but applicable more broadly. Summary box 12.4. First, you must use effective agents. Combining treatments that don't work individually isn't going to help. Seems obvious, but important. Second, ideally, you should use agents with different modes of action. If the treatments attack the cancer cell via fundamentally different pathways, there's a better chance of killing cells that might be resistant to one pathway, and potentially achieving synergy where the combined effect is greater than just the sum of the individual effects. Combining a drug that damages DNA with one that blocks DNA repair, for example. Third, try to use agents with non-overlapping toxicities. This is crucial for managing side effects. You want to avoid combining 2 treatments that both cause severe damage to the same vital organ system, like 2 drugs that are both highly toxic to the kidneys or bone marrow. Spreading the side effect burden across different systems makes the combination more tolerable. And fourth, consider spatial cooperation. This applies particularly when combining local treatments like surgery or radiotherapy with systemic treatments like chemotherapy. Chemotherapy travels throughout the body but might struggle to reach effective concentrations in certain sanctuary sites like the brain due to the blood-brain barrier or the testes. Radiotherapy, being a local treatment, can target these areas specifically. This explains, for instance, why prophylactic cranial irradiation, preventative radiation to the brain, is sometimes used in cancers like small cell lung cancer or certain leukemias that have a high risk of spreading to the brain, even if chemotherapy is also being given.
That makes sense. So while cancer management is often a long journey planned out over weeks or months, the source also highlights situations that require immediate attention, the oncological emergencies.
Yes, absolutely. While thankfully not common for every patient, there are a limited but critical number of situations that constitute true oncological emergencies. These require rapid recognition and urgent management to preserve life or prevent irreversible functional loss.
What are some key examples clinicians need to be vigilant for?
A major one is malignant spinal cord compression. This happens when a tumor, often a metastasis to the spine, presses on the spinal cord or the nerve roots coming out of it. If not treated rapidly, it can cause permanent paralysis, loss of bowel and bladder function. Management involves giving high-dose steroids immediately to reduce swelling, and then urgent treatment to relieve the pressure, usually with radiotherapy or sometimes neurosurgery. The key is to intervene ideally when compression is threatened, not after major neurological damage has already occurred.
Okay, cord compression. What else?
Neutropenic sepsis is another critical one. Patients receiving chemotherapy often have their white blood cell counts, particularly neutrophils, which fight bacteria, drop to very low levels. This is neutropenia. If they develop an infection during this time, their body has very little defense, and the infection can become overwhelming extremely quickly. It's a life-threatening emergency. Rapid diagnosis suspecting it in any febrile neutropenic patient and immediate administration of broad-spectrum intravenous antibiotics are absolutely essential. Time is critical. The faster the antibiotics are given, door-to-needle time, the better the chance of survival. And with the rise of immunotherapy, some severe immune-related adverse events can present as emergencies. For example, inflammation of the pituitary gland, hyperphysitis, or adrenal glands can cause life-threatening hormonal deficiencies. Immune-mediated diabetes can present suddenly. These need prompt recognition and management, often with high-dose steroids. Beyond these immediate life threats, the source also mentions many urgent situations that cause significant distress or can worsen rapidly if not addressed promptly. Things like deep vein thrombosis or pulmonary embolism, blood clots, malignant effusions, large fluid buildups around the lungs or in the abdomen, superior vena cava obstruction, blockage of the main vein draining the head and arms, and severe uncontrolled pain.
Right. So, shifting gears a bit, as cancer treatments improve, thankfully more and more people are living longer lives with or after a cancer diagnosis. The source discusses this under life after cancer, symptom control, and palliative care.
Yes, this is an increasingly important area. The impact of having cancer and undergoing treatment is profound and doesn't just stop when active anti-cancer therapy finishes. There's a growing population of cancer survivors who face long-term physical side effects of treatment, psychological challenges like fear of recurrence, difficulties returning to work, financial strains. They need ongoing support.
How does palliative care fit into this picture? And importantly, how is it different from end-of-life care? People often confuse the two.
That's a really crucial distinction to make, though the lines can sometimes blur in practice. The whole perception of cancer is shifting, as the source notes moving away from just cured or died, towards recognizing that for many, cancer is becoming a chronic disease that can be managed sometimes for years. Palliative care is about improving the quality of life for patients and their families facing serious illness. Its primary focus is on relieving symptoms, physical, psychological, social, spiritual.
And it can start early.
Absolutely. Palliative care can, and often should, be introduced early in the course of illness, even alongside active anti-cancer treatments aimed at cure or life prolongation. It's not just for the very end of life. The goal is symptom relief and maximizing quality of life, whatever the stage of disease. It involves managing pain, nausea, fatigue, breathlessness, anxiety, depression, the whole person. Table 12.7 outlines these holistic domains. Early referral to specialist palliative care teams can be incredibly beneficial for managing complex symptoms effectively.
So the transition should be seamless.
Ideally, yes. The transition from treatment primarily focused on cure or life prolongation to treatment primarily focused on palliation should be gradual and seamless, always centered on the patient's evolving needs and goals.
What are some common problems specifically addressed by palliative care interventions?
Well, managing pain from bone metastases, often using palliative radiotherapy or drugs like bisphosphonates, treating symptomatic cerebral metastases, sometimes with radiosurgery, draining malignant effusions and trying to prevent them recurring pleurodesis, managing thrombosis, blood clots, correcting hypercalcemia, high calcium levels, addressing fatigue, which is incredibly common exercise can actually help, managing weight loss and malnutrition with nutritional support, investigating fevers to distinguish infection from tumor fever, and recognizing and managing complex paraneoplastic syndromes. Now, end-of-life care is distinct. It's a part of palliative care, but it specifically concerns the care provided during the last few months of life. While excellent symptom control remains paramount, end-of-life care addresses the specific issues related to approaching death, such as potentially heightened spiritual needs, profound fears about dying, the specific needs of the family facing imminent bereavement. The source brings up the concept of a good death, which has deep historical and cultural roots. It emphasizes that facilitating a peaceful, dignified death, in line with the patient's wishes as much as possible, is a fundamental aspect of care. A patient only gets one chance for this. Summary Box 12.5 lists some specific issues pertinent to the end of life. These include sensitive discussions about the appropriateness of continuing or withdrawing active interventions. It touches on complex societal and ethical topics like euthanasia and physician-assisted suicide. Importantly, the source mentions these as topics relevant to end-of-life discussions in some societies, but takes no position, and our role here is simply to report that content impartially. It also covers the role of living wills or advanced care planning, providing bereavement support for families, addressing spiritual needs, supporting patients who wish to die at home if feasible, and being mindful of the potential for death to become overly medicalized, losing sight of the human and natural aspects of the dying process.
We've truly covered a vast amount of ground, really taking that deep dive into the principles of oncology, guided by our source text. We've journeyed from, the ancient history and cellular origins to the complex biology of cancer's hallmarks.
That rogues gallery of acquired traits.
Exactly. Then the interplay of causes, nature, and nurture. The multifaceted approaches to management, detailed diagnosis, sophisticated staging, the rules of surgery, the ever-expanding world of non-surgical treatments like radiotherapy and systemic therapies.
Targeted agents, immunotherapy.
Right. The principles of combining treatments, handling oncological emergencies, and then critically, the vital areas of supporting patients through survivorship, palliative care, and end-of-life care.
It really underscores how oncology is a field built on centuries of understanding, yet it's being absolutely revolutionized by molecular insights right now. And mastering this information, as professionals in this field strive to do, demands both appreciating that intricate science and never losing sight of the human impact, the person at the center of it all. It requires a truly collaborative, patient-centered approach.
Yeah, this deep dive really highlights that cancer isn't one single disease. It's this incredibly complex constellation of cellular processes driven by unique combinations of our own biology and our environment. And understanding these fundamental principles we've discussed is the bedrock for everything else, for diagnosis, for treatment development, and ultimately for improving outcomes and quality of life for millions of people.
So, considering how rapidly our molecular understanding is accelerating and how quickly these new targeted therapies and immunotherapies are emerging, here's something for you, the listener, to think about. Are we moving towards an era where managing many cancers becomes more akin to managing a chronic disease rather than the old binary outcome of cure or death? And if that balance continues to shift, what are the profound implications for patients living longer with cancer, for our healthcare systems, and maybe even for our fundamental understanding of health, disease, and mortality? What core principle or idea from this deep dive resonated most strongly with you?